I'm Michael. I'm one of the PGY2s in the emergency medicine program here. And as Dave mentioned, and Matt mentioned, I'll be talking today about the 2014 CCS guidelines on stroke prevention and how they suggest that we should possibly start them in the ED. So I have no conflicts of interest to declare. So just to give you a brief outline of my talk, so I'll first start off with a series of case presentations just to highlight different aspects of the CCS guidelines. Talk a little bit more about the pathophys of Afib and thromboembolic risk. Get into the deeper aspects of the CCS guidelines and the evidence for them. Then touch briefly on the NOACs, or the novel oral anticoagulants, which are now more commonly known as the direct oral anticoagulants. And then I hope to have a discussion with everyone here about prescribing oral anticoagulants in the eMERGE. And then finally, Dr. Richard Kim will come up to discuss the anticoagulation clinic and a little bit more on the NOACs and the newer referral form that we've developed. So just to preface this, I did not select the images for any of these cases. So we have a 63-year-old male. He presents to the emergency department. His chief complaint is he has these palpitations while he's mowing the lawn. He kind of feels this generalized weakness. His past medical history is significant for hypertension. He also has diabetes. He takes Ramipril on a daily basis. He has a 20-pack-year history of smoking, and he quit about 20 years ago. So maybe one of the residents, can anyone tell me what they'd like to know next about a case like this?
So just to complete my history, I want to know if he's ever had any episodes like this before, ever had any exertional chest pain in the past. And palpitations, is he feeling like chest pain? Is he short of breath? Is he very sweaty, anything like that? And then after that, I want a first set of vitals.
Perfect. Yeah, so definitely delve more deep into the history. So a little bit more on the HPI. So onset was about 30 minutes ago. He never had a similar episode like this in the past. He denies chest pain, shortness of breath, any symptoms suggestive of pre-syncope or orthostatic changes, and he has not lost consciousness at any point. His initial vitals, you can see here, his heart rate seems to vary between 130 and 160. He's normal tensive, and he's sat in well in room air with no fever. His cardiovascular exam, he's tachy. He's got these irregular heart sounds, and his respiratory exam was unremarkable. Next step in the management from this point.
Dynamically stable gentleman with a rapid heart rate. We don't have a ACG yet, so I'd like to get a formal 12-lead electrocardiogram.
Perfect. Yeah, great. So that's the next step would be to get an ECG. So as you can probably already tell, this gentleman has atrial fibrillation. It's kind of the goal of the talk.
Why is this Afib?
Okay, so if you look at the rate of patients going, as Mike said, about 130 to 160, so I'm not seeing any discernible P waves, and the rhythm appears to be irregular. So this is Afib. In terms of other concerning features on the EKG, I'm just looking at my ST segments there and my T waves, and I'm not seeing any. Just kind of taking a quick look right now. There is some. No,
Come on, it's EDSQ. Gotta go.
I think other than that, it's fine.
All right.
Yeah. So the main concerning factor in the ECG is the atrial fibrillation. So you diagnose him with Afib based on the ECG and his history. He is at this point at a low thrombolic risk, as we know from the previous CCS guidelines. His clear onset less than 48 hours. So you decide to cardiovert him. You can choose pharmacological or electrical. 30 minutes later, you repeat his vitals.
If you were going to pharmacologically cardiovert him, what would your options be?
Pharmacologically cardiovert him. I guess amiodarone would be a choice to use. That's all I can think of at the moment.
Lauren? Anything else you could use?
You could use procainamide, you could do the Ottawa protocol.
Okay, and how are you going to give procainamide?
So I give 1 gram over an hour and give strict instructions to watch for hypotension and increased QTC during that period of time.
Thank you.
All right, so patient's feeling much better. You now deem them safe to discharge home. So what would your follow-up plan be? So if everyone wants to log on, oh, they already answered. But if everyone wants to log on here and decide whether they should A, prescribe warfarin, B, prescribe a NOAC, C, prescribe aspirin, no anticoagulation is required. Follow up with a GP or anticoagulation clinic is D, and then no anticoagulation required at all. Patient safe to go home. All right, so most people seem to think that aspirin alone. A few more people. Anyone else left to answer? Yeah, so most people seem to think that aspirin alone is what they would currently do in their practice. All right, so let's go to case number 2. Case number 2 is a 67-year-old male, presents CED. He has palpitations, some overall weakness, about 20 minutes into his weekly bike ride. He comes to the emerge 2 hours after laying on the couch because he thinks that these symptoms might resolve on their own. Unfortunately, they do not. Otherwise, though, he has no other associated symptoms. He has a past medical history of gout. He also is taking multivitamins on a regular basis. He drinks about 5 beers per month, and he bikes to work. So he's a pretty active guy. So from this case, what would you do for this gentleman?
If he was cardioverted, same presentation as last time, cardioverted, stable.
All right, so once again, it seems like most people are leaning towards prescribing aspirin. All right, a few people said no discharge and then follow up with GP anticoagulation clinic. So we'll talk a little bit more about this a little later. We'll come back to these cases. Next case, a 64-year-old male comes to the emerge. He's also got the fluttering in his chest, started less than 3 hours ago. He's playing Wheel of Fortune at the Western Fair. His past medical history is significant for peripheral vascular disease and hypercholesterolemia, and he's on a statin right now. He says he drinks 1 to 2 beer per week. You clearly know he's lying. And he is successfully cardioverted in the emerge as well, and then you feel he's safe to discharge home. So what would you do in this case? Similar answers to before: prescribe warfarin, NOAC, ASA. Has anyone read the CCS 2014 guidelines in depth, out of curiosity? Okay, so we'll go through them more today, obviously, but most people seem to think aspirin would be their current practice. One last case here, 48-year-old male, palpitations 3 hours ago. He's successfully cardioverted. He was celebrating around the golf this weekend, had a few drinks, did not write this next part. He has a concussion in the past, and I'm not going to say the last part. How would you proceed with respect to anticoagulant use? It's the same thing again. These are your options once again. This one might not be active, actually. Oh, there we go. All right, so there's some split here: aspirin or discharge home and anticoagulant, or no anticoagulant at all. Fair enough. All right. Okay, good. So next thing I wanted to talk about was atrial fibrillation. Just touch briefly on this. So epidemiology, so its prevalence actually increases with age. About 4% of the population over age 60, 60 years of age, has atrial fibrillation. Oftentimes, though, patients' episodes are asymptomatic, so it's really difficult to tell exactly what sort of frequency with which they get these episodes of Afib. Some of the risk factors you've probably seen before are hypertension, coronary disease, ethanol excess, smoking, obesity, and obstructive sleep apnea. So atrial fibrillation, talking a little bit more about the pathophysiology. So 90% of new onset paroxysmal AFib is triggered by a driver, which is found in the actual cardiac sleeve, which is around the pulmonary veins, as you can see here. So basically, there's these ectopic foci that are found in these areas around the pulmonary veins. So precipitation of atrial fibrillation is actually thought to be secondary to atrial premature beats, which drive rapid firing. And then these ectopic foci respond in an irregular manner and basically generate irregular atrial responses, causing irregular contraction of the atria. A number of other driving factors mediate the progression of AFib. Some of them are shown in this diagram. It's beyond the scope of this talk in particular, but it's worth mentioning that it's a multifactorial process and it's very complex in how atrial fibrillation progresses over time. What is important of relevance here, though, is the different clinical forms of atrial fibrillation. So we have the first type is paroxysmal, and this is defined by self-termination within 7 days. The next step in the progression of AFib is the persistent type, which requires termination by pharmacologic or electrical cardioversion. And then finally, we have the permanent type, which is essentially defined by the fact that it's impossible to restore sinus rhythm. And you progress from a paroxysmal to a permanent form as the underlying heart disease itself progresses. So what are the mechanisms that actually mediate this progression into a permanent form of AFib? Well, AFib itself causes remodeling within the heart, so you get both electrical and structural remodeling. So electrical remodeling is when you get changes in ion channel expression, and you cause these re-entry loops. Whereas the structural remodeling is when you actually get cardiomyocyte death, you get fibrotic tissue, and then this modifies how the electrical signals are generated through the heart. Of relevance to this talk, though, is the thromboembolic risk associated with atrial fibrillation, and that is essentially set up by this atrial fibrillation remodeling, having an impact on stasis, endothelial damage, and hypercoagulability, which is the Virchow's triad. In particular, the thrombus most often forms in the left atrial appendage because it's a blind pouch where blood can actually pool. You also have endothelial damage, which is generated by inflammatory factors and growth factors. And then finally, you have a hypercoagulable state because of AF remodeling, which results in platelet activation and fibrinolysis. So let's come back to the case and go through them in detail and talk about how what the guidelines recommend at this point in time. So this first gentleman, he was 63 years old. He had a CHAD score of 2. He had hypertension and diabetes. So in preparation for discharge, the recommendation from the CCS at the present time is actually to prescribe a NOAC, which is the novel oral anticoagulant. And this is based on their recommendation that if you have even one of these CHADS risk factors, so prior stroke, TIA, hypertension, heart failure, diabetes, then they suggest that you prescribe an oral anticoagulant right from the emergency department. And so basically they say that it's prudent that we prescribe them in the emerge. So which one do we pick, though? They suggest these NOACs and not just the typical warfarin that we've seen in the past. And I'll talk a little bit more about these novel oral anticoagulants in a moment. And then the recommended follow-up for this is expert follow-up. So they recommend a cardiologist or an internist to follow these patients on a long-term basis. So what are these novel oral anticoagulants? Well, now they're more commonly referred to as direct oral anticoagulants. And that's because they actually exert their effects on specific factors within the clotting cascade. So more specifically, the factor 10A inhibitors bind reversibly to the active site of 10A within the clotting cascade here. Whereas, and examples of these are rivaroxaban and apixaban, which you've heard of, or Xarelto and Eliquis. And then the direct thrombin inhibitors, the bigatran, which acts specifically on the factor 2A. This is in contrast to warfarin, which is actually an indirect mechanism of blocking coagulation, and that's because it blocks a factor which is involved in activation of these it's a substrate which is needed for activation of these factors. So if it blocks vitamin K production via warfarin, then you prevent activation of factor 10, 9, 7, and 2 into their activated forms. So what is the evidence for these novel oral anticoagulants? Well, there's the RELY trial, which was published in 2009, which demonstrated that it was a non-inferiority study, and they basically demonstrated that dabigatran was equivalent to warfarin, if not a little bit better than warfarin at preventing patients from having a stroke. How about the factor Xa inhibitors? Well, looking at the Cochrane review from 2013, they looked at 42,000 patients with Afib that were spread out across 10 different randomized controlled trials. And these are all patients that were eligible for long-term anticoagulants in patients with Afib. Their primary efficacy endpoint was to look at all strokes. And what they showed is that treatment with a factor Xa inhibitor actually significantly decreased the number of strokes and embolic events compared to warfarin. So you can see there's an odd ratio of 0.81, which actually favors the Xa inhibitors. If you break this down into the two commonly used Xa inhibitors, apixaban and rivaroxaban, these actually accounted for 94% of the treatment effect that was seen across all the 10 different randomized controlled trials. And specifically, these, if you break them down individually, they both showed that there was either equivalence in the case or rivaroxaban compared to warfarin, or apixaban actually showed a decrease in stroke rate compared to warfarin. However, the stroke risk is not the only thing that we look at with respect to these anticoagulants. So one of the concerns is the risk of bleeding associated with both warfarin and the NOACs. So I've broken down here in the table form to show you that basically the risk of bleeding with NOACs compared to warfarin is actually increased with dabigatran, so major bleeds, GI bleeds, minor bleeding, and intracranial hemorrhages. However, with factor Xa inhibitors, interesting enough, there's actually a decreased risk of bleeding compared to warfarin. And specifically, there's a decrease in intracranial hemorrhage. But there's no difference in GI bleeds or minor bleeds when you compare it to warfarin. And I think this is probably why the factor Xa inhibitors specifically are more commonly prescribed nowadays than dabigatran. So let's come back to case 2. 67-year-old male. He presents with palpitations and history of gout. He's relatively healthy. His CHADS risk is relatively low. However, based on the new guidelines, he's actually over age 65, and they feel this is an important component of your stroke risk. And so they actually recommend prescribing a novel oral anticoagulant as well, straight from the eMERGE. So this is the new part of the guidelines, meaning the age greater than 65. Or having one of these stroke risk factors. And my understanding is that they actually wanted to call it CHADS 65 instead of CHADS 2, just because of this their thoughts that the age 65 is a key component in your risk of stroke. And this actually differs from the AHA guidelines, who recommend that we should give a choice to patients between no antithrombotic, aspirin, or oral anticoagulant. However, it's consistent with the European Society of Cardiology guidelines. All right, next case was the 64-year-old male. He had peripheral artery disease and arterial disease and hypercholesterolemia. In this patient's case, though, they feel that vascular risk factors do not warrant oral anticoagulant. And they say just to prescribe aspirin. So in that case, the majority of everyone's current practices is appropriate, according to the CCS guidelines. And that's this component here, which is coronary artery disease and arteriovascular disease. And they just say to ASA alone is sufficient in order to basically prevent stroke. So I wanted to bring your attention to the CHADS and the CHADS VASC, because the CHADS VASC was developed because they felt that vascular disease, age 65 to 74, and the previous stroke or TIA were important components in a person, or sorry, not the previous stroke or TIA, but female sex was important components in a person's stroke risk. And what was the evidence for this? Well, basically, just to summarize this case first, we have our 64-year-old male. The CCS recommends ASA alone and no oral anticoagulant. But what if you notice in his chart that his birthday is in 2 months? So he'll turn from 64 to 65. So you want to initiate a NOAC at that point. So based on that age criteria alone. So what if, in fact, he was a she? So the recommendation came from this study. In Denmark, they've actually been collecting patient data since 1978, and so that makes for a great observational studies such as this. So they had 73,000 patients with Afib that were not receiving an anticoagulant. And then their outcome of interest was admission with stroke or VTE or death from a venous thromboembolic event. And what they found is that at 1, 5, and 10-year follow-up, with vascular disease alone, you can see that there is an increase, but over time, which tends to be over 5 or 10 years. With female sex alone, however, there was no actual significant increase in their stroke risk at 5 and 10 years. But when you combine them together, there's a synergistic effects between these two factors, so vascular disease and female sex. So the recommendation now is if you are female and have vascular disease, you prescribe a novel oral anticoagulant. However, if you are a male with vascular disease, aspirin alone is okay. Finally, we have case number 4, healthy 48-year-old male, otherwise has no CHADS risk factors and he's less than 65. So in this case, no anticoagulation is needed at all. So I just wanted to kind of give a quick summary from all the CCS guidelines. So we have 3 different categories of patients. We have unstable, high risk, and low risk. Unstable patients, we proceed as usual to urgent electrocardioversion and then prescribe them an oral anticoagulant as an outpatient from the eMERGE, actually, according to the CCS guidelines. High risk patients, we rate control them because we don't know how long they've had Afib for. It could be more than 48 hours, which puts them at increased risk of having a stroke if they have a clot already. And therefore, you want to see them in an expert follow-up and do an echocardiogram. But the ones that I've been talking about today are the low-risk patients, which had a clear onset less than 48 hours, or they were the persistent type of Afib, which means that they had an anticoagulant for at least 3 weeks, and then you can electrocardiovert them in the eMERGE, and then prescribe them an oral anticoagulant. So at this point, I'm sure a lot of you have questions as to why are we prescribing oral anticoagulants in the eMERGE, and why do they feel we need to prescribe oral anticoagulants in the eMERGE? So I contacted one of the authors of the CCS directly, Dr. Ian Steele, who I'm sure you all know. Lauren made a reference to him earlier about his procainamide and protocol for pharmacological cardioversion of Afib. And I wanted to get more basically evidence or reasoning behind why they decided that oral anticoagulants should be prescribed in the emergency department. So I emailed them directly, and I asked what reasoning or evidence is there behind starting anticoagulation in the eMERGE. So you can read here, he didn't really allude to specific papers or evidence that suggests that we need to prescribe oral anticoagulants in the eMERGE before they leave the hospital. And he does feel, though, that we need to be taking on more responsibility for stroke prevention, according to the consensus from these experts. And I also asked, are the majority of the physicians at his site currently prescribing anticoagulants for new onset paroxysmal Afib? And he said that they're gradually coming around, but he feels that the knowledge translation takes time for physicians. But what evidence is this based on? So specifically what I was interested in is that if emergency physicians do not prescribe oral anticoagulants, are Afib patients actually at increased risk of a stroke within that first few weeks before they get to see someone in the oral anticoagulant clinic? So the first thing I looked at is, does the duration of Afib actually have an effect on stroke risk? So looking through the literature, I found no RCTs that exist to suggest that the early stages of stroke have an impact on, early stages of Afib have an impact on your stroke risk. But there is some indirect evidence. There's these 2 trials, the ASSERT trial and the TRENDS trial. The ASSERT trial was patients that were 65 years or older, and they had hypertension with no history of atrial fibrillation that was known, and they had a recently implanted pacemaker for whatever reason at the time. And they saw that greater than 6 minutes of atrial tachyarrhythmia was associated with increased stroke risk with a hazard ratio of 2.49 over about a 2.5-year period that they followed these patients. The TREND study, similarly, was a group of patients with greater than or equal to 1 stroke risk factor, whether it's hypertension or heart failure, for example. And these were also receiving pacemakers. And they found that greater than 5.5 hours of atrial tachycardia at any point in the 30-day period actually doubles the thromboembolic risk. So that's fair, but another consideration that we should have in the emergency department is what is the risk of thromboembolic events actually after we cardiovert a patient? So looking at this paper, the thromboembolic complications after cardioversion, this is a cohort of 2,481 patients in Finland. They were followed for 30 days after cardioversion of Afib. And you can see here that the baseline rate was 0.7% for a thromboembolic rate. However, if you have one of the CHADS risk factors, such as heart failure, or even more if you have diabetes as well, then you can see the thromboembolic rate actually increases quite significantly after being cardioverted from the emerge. Even age itself, greater than 60 years, has a slight increase in the thromboembolic rate compared to the baseline. And then finally, one last thing I thought would be important to consider in the emergency department is whether adherence to oral anticoagulants prescribed in the emerge is worse than those prescribed in an outpatient setting. And this paper was actually published by Claire Atzema in Toronto using the ISIS databases, which is the administrative databases. And they were wondering, based on the CCS guidelines, and if we prescribe an oral anticoagulant in the emergency department, is there reasonable adherence at the 6-month and 1-year time point? So specifically, they saw that if a patient was prescribed a dose of warfarin, or a prescription for warfarin in the emergency department, then the frequency of patients that actually were still taking warfarin at 6 months was 75%. And similarly, at 1 year was also 75%. And this is compared to with patients who were not prescribed an oral anticoagulant. There's actually decreased adherence in those not prescribed an oral anticoagulant at 6 months and 1 year. So finally, I just wanted to ask, essentially, does Afib, without anticoagulation, have an impact on stroke risk even for short periods? Well, the evidence seems to be limited. There's observational data that I just presented to you that suggests it may impact the long-term stroke risks. The CCS recommends that we take ownership of stroke prevention and start in the emerge. And what I wanted to ask the audience today is, does the current evidence support the aggressive prescription of an oral anticoagulant from the emerge? Does anyone have any thoughts on that?
Is anyone prescribing oral anticoagulants, warfarin, the novel? Dr. Roulette.
So, sometimes I do it from the community because, I don't know, they seem to have pretty good follow-up. But here, because they seem to have good follow-up with Dr. Kim and Dr. Dresser's clinic, I tend not to prescribe it at all lately. I don't know if that's right or not, or if anybody else is doing that. But the turnaround time, Dr. Kim could maybe tell us what the turnaround time is, but turnaround time seemed to be pretty good when it was first started. So it seemed like we could start the warfarin at their clinic, or start a Pixaban at their clinic, where it's in the community, I just started myself.
It's good you bring that up because we had a meeting with Dr. Kim who will come and speak in a little bit, and we discussed that specifically about what sort of follow-up we can arrange for these patients if we don't prescribe an oral anticoagulant from the emerge directly, and if we leave that up to them.
What is anybody else doing, if you care to share?
Has anyone prescribed an oral anticoagulant directly from the emerge? How's your experience with it? Yeah, please.
I do with Afibs, and then I send them hopefully to the clinic and their family doctor to check the INR in a few days.
You have started, and then you get the family doctor to check INR. Fair enough. Does anyone else have a fear of starting an anticoagulant for any reason? Do you think that it's too risky? Yeah.
Just out of ignorance, are any of them covered on ODB?
Yeah, good question. So the current Ministry of Health determined that we should at least do a trial of warfarin first. And then there's limited use codes for rivaroxaban and apixaban, which I can give you the indications for if you're interested at the end. But basically they say that a trial of warfarin is the first line. So that's something that maybe at the Ministry of Health level, if they were to push these guidelines a little more heavily, then they'd have to make that modification, I'm sure.
These codes refer to failure of warfarin or unable to tolerate warfarin or high risk for warfarin. So looking at them, most of them don't apply to the emergency department because they do suggest a failure of warfarin first.
It tended to be relatively healthy apart from,
Yeah.
like, is there any change in the guidelines if the person has some bleeding risk, a previous history of a GI bleed or something else that might?
Right. And I think that's the discussion that they say that should be had, is whether or not, you know, they have a high risk of falls, have they had a bleed in, like, you know, 5 years ago and now they're okay, et cetera. So those are all things that they expect us to discuss, I think, with each individual patient to make sure that they're not at a higher risk than the average person. That would be...
Emergency department, because of, you know, that the time it takes to have these discussions, as we talked with Dr. Kim, you know, that's something that can be done at the anticoagulation clinic. So under the time constraints makes it much more difficult in our work environment.
There's sort of two elephants in the room. One is the knowledge translation and, you know, side effects and indications in different patient populations like renal failure and hepatic failure and what have you that we just, I don't think know, or I don't know. But the other elephant in the room is, you know, you're talking about initiating a therapy that has potential for harm that we no longer follow up, that we no longer take responsibility for, yet we are responsible for. So I think that's the difficulty, and probably the next biggest hurdle of something like this is to be more mainstream.
For sure, I think that's the concern with why they're being so with their aggressive push to prescribe them right out of the emerge, is because of all the risks associated with them, who's following up, et cetera. So, yeah.
Prescription for something that might cause a significant side effect, albeit low, and you'll never find me again. You know, and is that going to be followed up in the community? Is the family physician going to say okay, which I suspect a lot of them do when therapy is initiated, but I don't know.
Right.
About is even if you're able to have that conversation with your patient, a lot of times patients aren't fully aware of their own health information. So, you know, have you had GI bleeding? Obviously, if they have a big one at some point, a lot of times they know, but they might not know that they're at risk for it because of other things. You know,
Absolutely,
And so that sort of worries me, or the patient that's like, oh no, you know, I don't have falls, but we don't know that they may have a drinking problem and may have had 4 falls in the past 4 years. And so I think that, yes, there's risk, but even a doubling of risk is like, you know, a 0.5 to now a 1% risk over the course of a year. And I'm just not sure that I have enough information. Like, I know what, maybe then know what the benefit is. I'm not sure, even with a discussion with the patient, that I have enough information to assess what their risk is. I think that's what makes me uncomfortable.
That's another issue, is time, like the time that's spent on that patient to make sure that they don't have any of those risks associated with prescribing these. So, yeah. Yep.
Indication anywhere how long we're supposed to write a prescription for? Like, I'm diagnosing you with this, I'm going to prescribe something for a month, and then send a copy of the chart to the family doctor saying, for this reason, I think they need to be on it long term, please assess? Or am I supposed to prescribe 6 months?
Yeah, I see what you mean. I don't remember reading that specifically in the guidelines. Did you see that? No. Yeah, I didn't see anything specifically about how long you should prescribe it. I guess they expect you, there was a push for expert follow-up, they called it. So cardiologist or an internal medicine physician who's knowledgeable in the NOACs or these DOACs, or warfarin for that matter. So I guess they assume that you would probably get earlier follow-up as opposed to later. So not like 6 months, but like say within a few weeks or a month. All right, so at this point, I just want to invite up Dr. Richard Kim. He's going to talk a little bit more about the NOACs and Afib.
So first of all, I'd like to thank Matt and Mike for asking me to be part of this. We do get a reasonable number of patients from your division in terms of patients with new diagnosis of Afib or paroxysmal and anticoagulation clinic function. So a lot has changed in the past 8 years since we developed the first kind of referral form. And so when Matt and Mike approached me about this guideline, gave me a bit of a chance to also kind of connect with you a little bit regarding some of the other things we're doing and some of the things we don't want to do. For example, in the very beginning, when we had modest business, we actually offered rate control and rhythm control on top of our warfarin dosing, because the warfarin was the only thing available. But the reality is now timely service as well as focusing on anticoagulation is the right thing to do. So at the end of my 10-minute presentation, I'll show you our new referral form. And one of the members from our group, Robin Legan, has the actual paper copy. And I hope you magically put it in your system and replace the old one. So that you see that this is a far better way to ensure that we have good communication and timely service. And I think some of the questions that was raised regarding am I really obligated to write this? Who's responsible? Well, if you write it, you're responsible. As you know, until someone takes over the patient, you're responsible. And in reality, you're absolutely right. These are drugs that have significant risk for harm as well as obviously benefit. Stroke risk is statistical and it's calculated over a year, so it is true. What is the risk for harm during that first bit of time when no one's responsible? And the other question that was really good was, how long do I write the prescription for? And that's a good question, mainly because we know, especially with the direct-acting oral anticoagulants, as soon as it clears the body, the patients become actually at risk for thrombosis, i.e. the baseline problem. So there's certainly plenty of evidence to suggest that missing doses or having gaps in therapy is a bad thing. So it would be a bad thing to write a prescription for a month and then they don't get anything and then something happens. So I think one has to be a little bit careful about prescribing and walking away without clear linkages. So that's kind of one of the things, and I don't think there's a major concern, at least for a week or so or two, regarding suddenly starting an anticoagulant either, because doing a poor job with anticoagulant is probably just as bad or worse than not being on an anticoagulant during the initiation phase. So, so one thing I should say, the anticoagulation clinic at UH, we focus specifically on cardioembolic indications, as you know, DVT-PE, thrombophilia, those type of anticoagulation needs should be directed to the thrombosis clinic at Victoria Hospital. We try to do that behind the scenes, but there's plenty of experts in hematology that do that. So at UH, given that also it does have bulk of the cardiology services, we've really focused on cardioembolic, so all Afib and ventricular thrombus and all of those things. The other approach that we have utilized is technology. You may or may not really know, but a lot of patients you send to us, whether they start warfarin or direct-acting oral anticoagulants, we actually put into bear a lot of technologies, because our anticoagulation clinic here is part of our personalized medicine program, and those who are initiated in warfarin, we actually get their DNA to figure out genomics-guided dosing. We can turn around the genotyping within a day if necessary. And we start with the predicted maintenance dose based on genotype. And we have plenty of patients, actually, our genotyping suggests that they need 0.5 or 1 milligram a day. So probably not a good idea to send someone home on 5 milligrams a day and forget about following up, because you absolutely have to manage INR if you decide to do that. Also for the NOACs, it is very important to really have a clear sense as to dosing guidelines, selection, which in a busy merge setting may or may not be as easy for you. So again, you have to be a little bit careful and not to just prescribe the NOACs because they might come back bleeding. So this is just kind of indicate that we do have genomics-guided dosing. That was actually perfected in terms of genomics-guided loading and maintenance dose here at the London Health Science Center. So we have this nomogram called WRapid. We can turn over the results fairly quickly, and we can actually figure out the predicted maintenance dose. And as you know, warfarin starting on the maintenance dose takes about a week to 9 days to really work. So in principle, even if you really wanted the patient to have instant normal INR, it's never going to happen anyway. So that the theoretical thing about one should they have a blood thinner in their system right away, it doesn't quite make sense. And even with the direct-acting oral anticoagulants, if you think of steady state, time to steady state, 5 half-lives, you're looking at probably 2 to 4 days, most likely about 2 to 3 days minimum. But again, are you picking the right DOAC or the dose? So direct-acting oral anticoagulants, I showed this slide because I guess the same journal that published the CCS guideline a couple of years ago asked me to write a review on our thoughts regarding predictors of interpatient variation to the DOACs. And I showed this now a little bit, mainly because we've written our share of pretty cool papers in New England and Nature and those kind of big journals. I never get thank you emails or letters, but this one actually generated unsolicited thank you from people who actually use this type of information. So I think it is viewed as unbiased and helpful. And I have absolutely no drug company bias. So we actually make sure we don't have any conflict of interest because these are important topics. The DOACs are of clear relevance to personalized medicine as well, in part because it is cleared by key drug metabolizing enzymes and transport processes. So the thing I think for the trainees in the audience to recognize is we're always used to kind of INR and kind of warfarin, and you just do it once a day and you adjust dose. DOACs only work when it's in the system. Its anticoagulant effect is proportional to the plasma concentration. So if there's none in the system, there's no anticoagulant effect. So that's why you probably shouldn't do too many INRs or PT for your patients on a DOAC, unless you're thinking that there may be bleeding or there's severe issues, or there's, in part because the predicted PT, PTT, or INR would vary with plasma concentration that the patients experience. So you'd have complete difficulty interpreting what the numbers mean. And the other thing, if you're going to do this in emerge, you really have to pay attention to interacting drugs. So we've had a number of cases where we don't make a big deal out of it, but clearly some of the key interacting drugs were missed. So for example, it's not uncommon for some of our patients to be on drugs like amiodarone and other medications. We know for sure the plasma level doubles on those who are on amiodarone, so they need to be on much lower dose. And we've seen a number of cases where anti-epileptic drugs that induce drug metabolism. So for the trainees in the audience, the three to really just memorize rock solid is phenytoin, phenobarbital, and tegretol or carbamazepine. They will for sure induce drug metabolism. So the patients will get subtherapeutic benefit. So in fact, if you look at the kind of the current suggestions for dosing for the three DOACs, it is true, the Bigotran use has significantly declined due to the bleeding issues. DOACs are not recommended for patients on inducing drugs like Dilantin, phenobarb, and Tegretol. So it would be a bad idea to miss that, because we have seen patients who actually have Afib, maintained on a DOAC, and they're on antiepileptics because they got seizure from a previous stroke, for example, coming into the hospital and still staying on a DOAC without validation that the drug's working. So just be careful with that. In terms of selection, this is kind of a typical dosing guideline. So if you're going to do it, at a minimum, must pay attention to estimated GFR. You should calculate it from the most recent creatinine that you see, and then you have to ask about weight, and so you do have to spend a little bit more time. But just looking at creatinine alone wouldn't be sufficient, because you have to break the creatinine clearance into multiple, severe, end stage, moderate, and normal. So there are some possibilities of dosing, but in reality, for severe end stage renal disease, warfarin is the main drug. The question of GI bleeding or history of bleeding tends to be a tough one. So we kind of think of it as kind of, if they actively have bleeding, obviously, anticoagulant is probably not warranted until you know where the source of bleeding or severity of bleeding. But we think of at least 2 to 4 weeks after the most recent bleed, it should be sufficient time for you to go ahead and initiate anticoagulation, because sometimes people are very fearful, so they don't want to start. But if you look at the data, a major stroke is much more disabling than a bleeding risk. So you can't have too much time go by without anticoagulants either. So the reason why our clinic has really kind of, that you may or may not know, that we've done this for the past 2 years now, offer therapeutic monitoring for DOACs, in which we kind of know, based on the plasma concentration, what the therapeutic range should be. So it's kind of like your Tylenol overdose nomogram. You can kind of guesstimate, because a lot of patients will ask you, I heard there's no antidote, I heard that you don't know if it's working. So then it's true, technically. So then we believe therapeutic monitoring is the way to ensure therapeutic benefit. And you can see in this slide, the predicted kind of the shaded area would be the therapeutic range. And there's actually quite strong evidence from the RELY trial, as well as the latest data set from edoxaban, which actually the ENGAGE TIMI trial shows bleeding risk is proportional to blood concentration. Thrombosis risk, ironically, is not actually. If you run the blood concentration in the low to mid level, you actually get just about the same thrombosis or stroke prevention as people running high levels. So again, it does kind of says that since patients vary a lot, that having 1 or 2 doses may not be sufficient. So we do use our mass spectrometry. Our record is same-day measurement, but we try to do this once a week, but if necessary, we can do it more frequently. And then we do have automated ways of plotting this type of data into a pharmacokinetic profile, and our dictations usually include a picture like this, so you can visually tell whether the patient's numbers look pretty good. And we have plenty of cases where we're the only service, I think, that actually write off not recommended dosages of tiny dosages, as well as doses you would never prescribe, including double of the maximum dose for some of the NOACs. But we take on the legal liability because you have to fully explain. But some of the patients actually require tiny doses or big doses if they can't tolerate warfarin for whatever reason. And this is some of the data that our group has that demonstrates that, in fact, clinical decisions for even the NOACs don't do a great job, actually. So we try very hard now. This is when we first get the patients and their first plasma level, suggesting that even with the dosages and clinical decisions that we base on renal function, there's still profound interpatient variation. So the last thing I wanted to show you is the kind of the referral form. I know you want us to be like a next day urgent medicine clinic, but the reality is this is Afib, this is not PE. So it's really kind of statistical risk for stroke. So if you want to start something, that's fine with us, but we will endeavor to see all your patients within a week or 2. But I think historically we struggle a little bit trying to triage who's really urgent versus who's just had an AF. So we've talked to our team, various docs, as well as our pharmacists in the clinic to create this new version of the anticoagulation referral form. And it basically gives you big check boxes. So we want a little bit more information, and we'll get an idea from you what you really want. And then we do have 3 half-day slots each week. So we're going to try to open up 1 or 2 extra slots in each of the clinic for truly urgent cases. But we don't want to promise next day service for every patient, because the reality is this is not life-threatening at the moment that you see the patients. At least for AF, for most, vast majority of patients. If you're so worried, I mean, theoretically, you should give them a big, a prescription for fragment and then have them see someone. But I suspect that for AF, you don't do that. So, so just a little bit of information, and then fax us. There's a fax number, all that stuff, and then we will figure that out. And the part of what we want to do is then have kind of again, this notion of appropriate management, right specialties, and then connecting the dots so that you have a constant kind of a sense of how we do business, but also if you let it go, that someone will pick it up. So I think that's what we want to do. So like I said, that's why we now no longer really want to focus on rate control or those kind of cardiology or internal medicine kind of follow-ups, in part because those patients, especially older patients, require significant follow-ups for managing rate control meds, and there are plenty of cardiologists in clinics as well as internists that are very good at those kind of things. But what we want to do is the first month or 2 that we know, especially during initiation of therapy, is the most important time for our patients in terms of figuring out the best anticoagulant. So I think that's all I have. So any questions? Yeah.
When a patient stops taking a novel anticoagulant, is there rebound hypercoagulability or not?
I think that is, it's hard to say it's truly rebound per se, but there have been significant data suggesting the rate of stroke or event rate is much higher when there are gaps. And this is probably more of a problem, especially for critical thrombosis like DVT-PE. We have seen cases, or certainly have heard of patients missing 1 dose even, where they start with a DVT, miss 1 dose, come back with fulminant PE. So it does look like, at a minimum, baseline coagulable state, but there may be a slightly higher coagulable state. Hard to prove, but if you look at the stroke rates in people who have gaps, it is significantly higher.
About the length of time that a patient is actually followed up in the anticoagulation clinic, because I see such a dichotomy for options of care. So from the emergency department, if I send a patient to their family physician and the family doctor chooses a novel oral anticoagulant, the family physician is not going to be monitoring plasma response to adjust the therapeutic window of the drug. So I'm just wondering how long the patient actually stays attached to the anticoagulation clinic before they're then, I'm assuming, released back to the family doctor who doesn't have the capabilities of doing that.
Yeah, no, and whether it's warfarin or the direct-acting oral anticoagulants, we believe the first 3 months is the most critical. And once you either get settled on warfarin or the NOACs, it's actually fairly easy to manage. We do always ask our patients about their relationship with their family docs. A significant proportion of our patients have poor relationships or no family physicians. And occasionally we have patients with no phones. So, so it really does say the follow-up strategy is very important. So we do try very hard once we know by the we see our patients and start to manage them, but certainly by 3 months make a decision regarding should our clinic help to manage, or should we connect with family docs? And we do, our pharmacists always kind of touch base with the family docs if we think we can let go. For NOACs, we do try to see them maybe once a year if that's what they prefer, just for levels, just to ensure, because renal function changes, drug interactions changes, because it shouldn't be just kind of a plug and play. It does vary a little bit, because we do have, a lot of our patients are older and they get comorbidities and drug interactions, so it's probably not a bad idea. And also, different drugs come on the market, and it's probably not a bad thing to review, you know, should they be on. So I think in principle, a specialized clinic as ours to do a more standardized assessment about the type of anticoagulant as well as switching and dosing, and then once stabilized, send them back to the community physicians. That's what we currently do, but we know there is some variation in terms of our ability to send back. The patients that we worry about a lot, we actually hold on to them. Not that we like to do that, but it's all about safety and bleeding risk, because we know they'll become regular visitors to emerge with the bleeding problems. And the ones that have, for example, mechanical valves, even if they're doing well, we really try hard to hold on to them, because occasionally, or these, you know, for example, mechanical mitral valve, if you do a bad job with warfarin, it can be life-threatening. So I think the right thing would be to at least have our clinic have a go at that, and then we send back the vast majority of patients to the community, because no, we would not have the capacity to see everybody in the city, but it's the right thing to do when in the beginning you don't know what is the best anticoagulant.
That's great, thank you. I hadn't been using your clinic probably until this point at all. So I kind of get the sense that the first part of the knowledge translation, actually just on that just that slide you're just on, wherever it says OAC, we're now talking about referral to anticoagulation clinic.
I think that would be one kind of strategy. I think all of you have the ability to do kind of the right thing and all that, but it is a function of if you have, I guess, a center, we're an academic medical center, we have a very specialized capabilities. You know, we have genomics guided as well as mass spectrometry-based levels. And also, if you actually have patients who's bled and you're worried, you know, that they have, was it the rivaroxaban or apixaban that caused the bleed, regardless of whether their Afib is okay or not, it'd be a fair game to say, you know, are they on the wrong one? So I think that would be the, I think, easier and possibly over time more of a standardized option than trying to go through all the checklists in eMERGE.
Yeah, to be clear, your pictures are pictures of why I don't do it in terms of your spectrometry and what have you. So if, just as a matter of practicality, so if I'm now referring someone with new onset AFib, are we doing a kind of a dual consultation for the workup of the AFib? Like in terms of, people getting echoes and what have you? You're doing...
I think that you can do as you wish, but we kind of see two separate pathways. So if you send them to us and no echo was done, we'll order one. But then it's possible we may still, and if there's no cardiology or internal medicine involved, we may still triage that further in terms of sending those over. But we would like the request to be, we believe this patient needs anticoagulation. I want you to do something or not, right? So but ideally, if they don't need anticoagulation, they need some echoes and rate control and EP service to be involved. We don't want that consult because we'll end up just, faxing a real request to the EP guys or cardiology folks in terms of further workup. Because it takes a lot of, if we have a cadre of these patients where we do a lot of Holters and follow-ups, it creates kind of ambiguity. We don't want to be good at things we're not good at. But on the anticoagulation side, I think you should know then, this is the only clinic in the country that will actually do these things for you. And the plasma level is proportional to factor Xa activity. Factor Xa activity is very difficult to measure, huge lab-to-lab variation, and no hospital lab wants to do it. So it just seems like you have the luxury of leveraging off of us. And as I say, this is part of our personalized medicine program. We have multiple physicians as part of our team. We have a pharmacist support. So it's like almost like a free service for you. In other centers, you'd have to kind of beg and plead a little bit. But what we want to do is just connect with you so that we don't get inappropriate consult requests to us. So we do a good job on the ones that you're really thinking that we think he or she needs anticoagulation, but we want you to figure out which one. And we will do the warfarin thing, and we'll do the 3 months, and then we'll figure out, and we switch easily, and then we can fully justify using the LU code, because as taxpayers, probably isn't the best thing just to kind of say, well, DOAC is the way to go, because that's what it says. The reality is bad DOAC is probably going to be just as bad as warfarin, or even worse in some cases, if they come back bleeding.
Thanks again for your talk. It might be useful having a second page with that referral, just saying here are the options of starting stuff. I'm not sure. I mean, it looks like everyone's going to start on warfarin essentially, since ODB coverage.
But a lot of patients have private coverage, and some patients don't mind paying for it, and so there are various options. But I think in an emerge setting, it is an awkward conversation because people are stressed, and you say, well, it's kind of expensive. It's about $150 a month out of pocket.
How would you want the warfarin started? And if you're not going to see him in 2 weeks,
So if you really want to get warfarin started for whatever reason, right? The first 2 doses or 3 won't make any difference, right? But if these referrals come in and you say, I was so worried, I started warfarin. We know time to target INR will be about a week or so, but we know someone has to start monitoring INR or possibly do the genomics. So we would have to triage that. But
over 65, you're essentially telling us they need to be on warfarin, so I'm not worried that I'm following the guideline where they say start them on warfarin.
No, so I think for us, if there's no cost issue for AFib, we have no problem patients starting DOACs right off the bat for AFib. It's really, I think, vast majority of our patients in our clinic, when we really talk to them, it's all hunky-dory until you tell them it's kind of expensive. And then it's a deal breaker. So there's a significant proportion. And also about half of our patients who are started on warfarin do actually very well. Very stable, and time in target INR of 70 to 90%, which we believe is as good or even better than any direct-acting oral anticoagulant. So you could press the easy button, but within that proportion of patients, there are some that would have done fantastically well on warfarin.
Page would be helpful for us. So saying, hey guys, if you're going to start on something, here's the dose. Watch out for kidneys. Watch out for hepatic problems.
Reference that might made up with the different dosages, costs, and might make that available for people who are interested.
Yeah. So what we can't be on the hook though is to guarantee we'll see your patient within 2-3 days to start taking over. Because we tell the inpatient side the same thing. Some of the services, when they are just about to send patients home, they call us saying, we want to send this guy home. Can you look after the INR? Well, no service does that. We need to know your patient before we take over your patient. Otherwise, you have this huge medical legal liability of assuming care when you don't even know the patient. So we really need clarity of expectation. Vast majority, I think, for Afib, I can't imagine why 1 week would be such a deal breaker.